Welcome to the deep dive. Our mission today, well, it's to cut through the noise and really synthesize the core, actionable intelligence you need for managing thromboembolic disorders.
Exactly. We're talking advanced practice level here.
We're diving deep into the pharmacotherapeutics, covering everything from DVT and pulmonary embolism, that's VTE, to stroke prevention and atrial fibrillation, and yeah, that tricky issue of prosthetic heart valves.
Yeah, this is definitely a high-stakes area of pharmacology. We aren't just memorizing drug names and mechanisms today.
No.
We're establishing those foundational principles, the pathophysiology that defines the risk, the diagnostic scores that actually guide our therapy, and maybe most importantly, the safety management for these critical, but let's face it, inherently dangerous agents.
Let's start right there, defining the clinical problem, specifically venous thromboembolism, VTE. The risk stratification, it fundamentally relies on Virchow's triad. I mean, for anyone stepping into advanced practice, understanding this is just non-negotiable, right?
Yeah. Absolutely. Virchow's triad, it's the classic framework. It dictates where VTE risk actually comes from. It's a convergence of three factors.
Okay.
You've got venous stasis, that sluggish blood flow you see with immobility, long flights, maybe post-surgery. Then there's vascular wall injury, could be trauma, surgical damage to the endothelium.
Right.
And finally, hypercoagulability. This might be inherited, like factor V Leiden, or it could be acquired through things like cancer or certain hormone therapies.
So when those three overlap...
That's when you have a patient really primed to form a venous clot.
Okay, so let's unpack how that clot actually forms once those Virchow factors are in play. So vascular injury kicks off the clotting cascade, right? This sequence converting inactive factors step by step into activated complexes.
Correct. And the end goal is always the same. Generate factor 2I, which is thrombin. Thrombin then converts fibrinogen into that stable fibrin mesh that makes up the clot.
And here's a really crucial distinction, something you really need to carry forward in practice. Not all clots are built the same. The location really defines the treatment approach.
Exactly. Venous thrombi, they form in areas of low flow, typically the deep veins of the legs. Compositionally, they're mainly red cells and fibrin.
Which makes them the target for anticoagulants, ACs.
Precisely. Now, contrast that with arterial thrombi. These form in high-flow, high-shear environments, like over a ruptured atherosclerotic plaque.
Think heart attack, stroke.
Right. And these are platelet-rich clots, stabilized by some fibrin. This difference in composition explains why our treatment for arterial events like secondary prevention after a stroke, or TIA, relies heavily on antiplatelet agents, APs. The type of clot dictates the class of drug. It's fundamental.
So moving from the cause to the clinic, diagnosis. Let's say a patient presents with a swollen, painful leg. Suspicion for DVT is high, naturally.
But clinical factors alone, they're notoriously unreliable. We know less than, 20% of suspected VTE cases actually turn out to involve a clot.
Which is why we lean so heavily on objective testing, but married to clinical probability scoring, like the Wells or Geneva scores mentioned in the source materials.
And the foundational test here is the D-dimer. It's highly sensitive, measuring those fibrin breakdown products.
So the clinical pearl with D-dimer is really its negative predictive value, right?
Exactly. If the D-dimer is negative, usually meaning under 500 in GML, you can pretty confidently rule out DVT or PE if the patient is low risk to begin with. It's primarily an exclusion test.
Okay.
But for those with a low pretest probability of PE specifically, we sometimes use the PRC rule. That's the pulmonary embolism rule-out criteria.
Ah, right, where you check those 8 criteria, things like age under 50, heart rate under 100, no unilateral leg swelling.
Yep. And if the patient hits 0 of those criteria, you can often exclude PE without needing imaging or even a D-dimer. It's quite an elegant tool. Helps reduce unnecessary testing.
Okay, shifting gears a bit. We need to apply this kind of risk thinking to another major thromboembolic threat. Ischemic stroke linked to atrial fibrillation, or AFib.
AFib, yeah, it's the most common rhythm disturbance we see. And that pooling blood, particularly in the left atrial appendage, is just fertile ground for clots to form.
And to quantify that risk, we turn to the CHA2DS2-VASc score. It's a calculation based on factors like age, vascular disease history, prior stroke.
And it helps estimate the patient's annual risk of having an ischemic stroke. That score then directly informs the intervention. Oral anticoagulation, OAC, is typically recommended for men scoring 2 or more and women scoring 3 or more.
So this brings us to the overall therapeutic goals. We're trying to prevent stroke in AFib and with mechanical valves, and for VTE, we want to prevent the thrombus from extending or recurring.
But before we jump to prescribing, we have to weigh that benefit against the inherent cost.
And that cost is bleeding risk. The absolute contraindications to systemic anticoagulation are critical to know.
Absolutely critical. Active major bleeding, obviously.
Uh-huh.
Recent intracranial hemorrhage. Severe thrombocytopenia.
Or pregnancy, if we're talking about warfarin or the DOACs, because they cross the placenta.
Right. Which is why UFH or LMWH are often the only parenteral options available for pregnant patients who need anticoagulation.
Okay, let's move into the drug classes themselves, starting with the parenteral agents. Unfractionated heparin, UFH, LMWH, and fondaparinux. UFH is the veteran, the old workhorse.
It is. Its mechanism involves binding to antithrombin III, or AT3. This binding dramatically boosts AT3's power to inactivate a whole host of clotting factors, most notably factor Zada and thrombin, which is factor 2A.
But the clinical headache with UFH, though, it stems from its properties, doesn't it? It's a large molecule.
Yep, large molecule, poor bioavailability when given subcutaneously, only about 30%, and crucially, a nonlinear dose response. Small dose changes can have huge, unpredictable effects on clotting time.
Which is why, when you use it therapeutically as a continuous 5V infusion, you absolutely need a weight-based nomogram, like the one concept described in Table 49.3, and really aggressive monitoring, usually tracking the APTT every 6 hours until you're stable.
It's intensive. Now, contrast that complexity with the low molecular weight heparins, LMWHs, which are essentially fragments of UFH.
And fondaparinux, too, right?
Yes, fondaparinux is a synthetic pentasaccharide, even more specific for ZO. LMWHs and fondaparinux were designed for predictability. They preferentially inhibit factor ZO over thrombin.
And the clinical advantage there is pretty staggering.
It really is. They have much better subcutaneous bioavailability, over 90%, a longer, more predictable half-life, and importantly, a linear dose response.
Meaning routine monitoring generally isn't necessary?
Correct, which allows for outpatient management, a huge benefit.
Yeah.
But here's an important little nugget for you.
Okay.
Due to differences in how they're made and their exact molecular weights, the various LMWHs like dalteparin and enoxaparin are not considered therapeutically interchangeable. You can't just swap them willy-nilly.
Why is that distinction so crucial? I mean, if they both largely hit factor ZA, why can't I just switch brands?
Well, because the precise ratio of factors ZA versus thrombin inhibition and their clearance kinetics, they are slightly different between the brands.
Ah.
So if you switch a patient without proper dose adjustment or consideration, you could risk either bleeding from too much effect or therapeutic failure from too little. You really have to treat them as unique drugs.
Especially if you're thinking about monitoring anti-ZACSA levels in those high-risk groups, like patients with severe renal dysfunction or maybe morbid obesity.
Exactly. Monitoring isn't routine, but it's considered in those specific populations.
All right, moving to the mainstays of oral therapy. Let's start with the old reliable warfarin, a vitamin K antagonist, or VKA.
Right. It works by messing with the liver's ability to recycle vitamin K. This leads to the depletion of vitamin K-dependent clotting factors, 2, 7, I, X, and X.
But the real clinical challenge with warfarin isn't so much the mechanism itself, it's the timing, isn't it?
It absolutely is. Factor 2, thrombin, has a very long half-life, around 60 hours or so. Because of that long half-life, the full antithrombotic effect takes quite a while to kick in. We're talking 8 to 14 days.
And that delay leads directly to the famous bridging conundrum.
Yes,
Yeah.
because warfarin also rapidly depletes protein C. Protein C is one of our body's natural anticoagulants, and it happens to have a very short half-life,
So you knock out an anticoagulant first.
creating a temporary hypercoagulable state right when you start warfarin. It's counterintuitive, but critical to understand.
Precisely. And to prevent clotting during that vulnerable window, warfarin must be overlapped or bridged with a rapid-acting parenteral agent like UFH or LMWH.
For at least 5 days, and until the INR is stable within the therapeutic range, usually for 2 consecutive days. That clinical insight that you're covering, the temporary drop in protein C, is what drives that bridging rule.
Okay, and monitoring warfarin requires precision. The INR, the International Normalized Ratio.
Derived from the prothrombin time ratio and the ISI, the International Sensitivity Index.
It's the only test used for adjusting warfarin doses. It's designed to standardize results across different labs, different reagents.
Absolutely. Our target INR is typically 2.0 to 3.0 for most indications, although we push that higher, maybe 2.5 to 3.5 for certain high-risk mechanical heart valves.
And when adjusting the dose, you have to remember that nonlinear response curve.
You do. Maintenance changes should generally be modest. Think 10% to 20% of the total weekly dose. You have to be patient with warfarin adjustments. Small tweaks.
Okay, now let's get to the modern options. The direct-acting oral anticoagulants, or DOACs.
Right. Two main classes here. The direct thrombin inhibitor, which is
Right.
dabigatran,
Pradaxa.
and the oral factor zeta inhibitors like rivaroxaban, apixaban, and edoxaban.
Xarelto, Eliquis, Savisa.
Exactly. And the major clinical advantage here is speed. These agents hit their maximum concentration and full anticoagulant effect really quickly, usually within 2 to 4 hours.
Which means?
Because they work so fast, that whole bridging requirement with injectables when starting therapy, it's generally unnecessary. You can often transition directly.
That's a huge simplification compared to warfarin initiation.
Huge. However, the dosing is complex in its own way. It's highly individualized based on the indication VTE treatment versus stroke prevention in AFib, for example, and, crucially, on renal function, the patient's creatinine clearance.
And you also need to be aware of drug interactions, especially with P-glycoprotein inducers,
Yep.
right?
PGP interactions are important, but also some specific black box warnings. For instance, edoxaban actually has reduced efficacy for stroke prevention in AFib patients who have very good renal function, a high creatinine clearance, typically over 95 millilaumin.
That's counterintuitive again. Better kidney function, less drug effect.
It seems so, possibly due to faster clearance, but it's a critical detail. Missing that could lead to therapeutic failure, to a stroke. You must check CRCL before prescribing edoxaban for AFib.
Wow, okay, good to know. Now, to briefly touch on arterial prevention, let's look at the antiplatelet agents, mainly for secondary stroke or TIA prevention.
All right, we have aspirin, the classic. Irreversibly inhibits the COX enzyme, stopping platelets from making thromboxane A2, which is a potent platelet aggregator.
And the dose is key here.
Absolutely. Lower doses, usually 81 milligram daily, are preferred. Higher doses significantly increase the risk of GI bleeding without really adding much benefit for stroke prevention.
And then there are the P2Y12 inhibitors, like clopidogrel, Plevix.
Yep, clopidogrel, it's a prodrug, needs to be metabolized by the CYP2C19 enzyme to become active. It's often used in dual antiplatelet therapy, DPT.
So aspirin plus clopidogrel.
Right. Usually for the first 21 days or so after a minor stroke or TIA. The idea is to maximize platelet inhibition during that high-risk acute period.
Okay, so let's try to summarize some prescribing preferences for the listener. Put it all together.
Good idea. So for most VTE treatment in stable patients who don't have active cancer, the DOACs are generally preferred over warfarin.
Why is that?
Because studies show pretty equivalent efficacy in preventing recurrent VTE, but DOACs generally have a lower risk of major bleeding, especially intracranial hemorrhage.
Okay. And for stroke prevention in AFib, SBF.
Similar story. DOACs are generally the recommended first-line therapy over warfarin for most patients with non-valvular AFib. Again, similar efficacy, better safety profile overall.
But the major exception remains.
Mechanical prosthetic heart valves.
Hmm.
Here, warfarin is still the undisputed lifelong standard. DOACs are explicitly not recommended for prosthetic heart valves based on trial data showing worse outcomes.
And the INR target for warfarin in these valve patients is non-negotiable, and it varies depending on the type of valve and its position, right? Mitral versus aortic, older versus newer generation.
Absolutely. Very specific targets, usually higher than the standard 2.0 or 3.0 range.
Okay. This brings us squarely to the biggest risk inherent in this entire field: bleeding.
It's the most worrisome adverse event, always. Our job isn't just to prevent clots, but to do so as safely as possible, which means actively mitigating bleeding risk.
And we use risk assessment tools for that, like the HAS-BLED score for AFib patients.
And the VTE-BLEED score for patients being treated for VTE. These scores help us identify modifiable risk factors.
That distinction is really key, isn't it? We're looking for things we can actually do something about.
Exactly. Things like uncontrolled hypertension, which massively increases bleeding risk, or the inappropriate concurrent use of other drugs that affect bleeding, like antiplatelets or NSAIDs, without a clear indication. Managing those modifiable factors is crucial.
And what about when major life-threatening bleeding does occur, despite our best efforts? We need to know the reversal agents.
Absolutely vital. For warfarin, reversal involves giving vitamin K either IV or oral, depending on urgency, plus a rapid-acting agent like 4-factor prothrombin complex concentrates, 4-FPCCs, which quickly replenish the clotting factors.
Okay. And for the DOACs, we have specific targeted antidotes now, right?
We do, which is a significant advance. For dabigatran, the direct thrombin inhibitor, the antidote is a dorosizumab. It's a monoclonal antibody fragment that binds directly to dabigatran.
And for the factor Zago inhibitors, apixaban and rivaroxaban?
For those, we have andexanet alpha. It acts like a decoy protein, binding up the factor Zago inhibitor molecules so they can't inhibit native factor Zeta.
But there's a gap, isn't there?
There is, and here's another clinical nuance. Currently, there is no specific FDA-approved antidote for bleeding associated with the factor ZAG inhibitor edoxaban. Management usually involves supportive care and potentially off-label use of PCCs, but there's no targeted reversal agent yet, adds another layer of complexity when choosing that specific drug.
Wow. Okay, so what does this all mean? We've really navigated the entire landscape here. From defining the clot with Virchow's triad, quantifying risk with scores like CHA2DS2-VASc,
Through the complexities of warfarin kinetics and bridging, the speed and nuances of the DOACs.
all the way to managing bleeding and knowing those critical life-saving reversal agents.
Yeah, the daily reality for the advanced practitioner working in this area is constantly balancing that efficacy, preventing the clot, with safety, minimizing bleeding risk, and maybe most critically, patient adherence.
That's huge. Think about warfarin. Its slow, steady management demands meticulous consistency from the patient. Every dose counts, every lab test matters. Even maintaining a consistent dietary vitamin K intake is important.
Right. It requires a lot of patient engagement and education.
Versus the DOACs. That rapid onset and, importantly, rapid offset is a clinical advantage in some ways.
Like if you need to stop it quickly for a procedure.
Exactly. But it fundamentally shifts the patient education challenge, doesn't it? If a patient misses even a single dose of, say, a twice-daily DOAC like apixaban,
They lose anticoagulant protection almost immediately. The effect wears off fast. The margin for error, adherence-wise, is incredibly thin compared to warfarin's long half-life.
it really raises a powerful question for your future practice, doesn't it? How does that rapid onset and offset profile of the DOACs fundamentally change how you teach patients about their medication and manage that risk compared to the slow, steady, arguably more forgiving regimen required for warfarin?
It's a completely different educational hurdle, different risks, different counseling points. Understanding that difference is key.
That really is the ultimate test of understanding in this field, balancing all those factors. Well, thank you for joining us for this deep dive into pharmacotherapeutics for thromboembolic disorders.
My pleasure.
We really hope this review supports your learning and helps prepare you for the complexities of clinical practice.